Hello everyone, my name is Dr. Vivek Patel and today I'm going to present on muscular dystrophy. I would like to thank AMIQT team for giving me this opportunity to talk. So these are the things we are going to discuss today. Introduction, genetics and epidemiology, clinical features, differential diagnosis, evaluation and diagnosis, management, prognosis and complications. So what is muscular dystrophy? Muscular dystrophy. Dystrophy means degeneration and muscular means muscle. So it is basically a degeneration of the muscle. It results from the defect in number of genes that are required for normal muscle function. So if these genes become defective, the muscle won't be able to function properly. So it gives rise to muscle weakness. And this is one of the main symptoms of the muscular dystrophy, and they are inherited and progressive in nature. Now let's see how the muscular dystrophy develops. So before we discuss that, I would like to talk about dystrophin. So dystrophin is one of the largest human genome, which is prone to spontaneous mutation due to its massive size. So the primary role of dystrophin is to connect the cytoskeleton to the extracellular matrix. So whenever there is mutation in the DMD gene by point mutation or deletions or single nucleotide variants, it leads to partial deficiency or complete absence of dystrophin. And this affects the dystrophin galactoprotein complex, which in turns affect the permeability of the muscle membrane muscle membrane, which is called sarcolemma, which in turns lead to influx of the calcium from outside into the cell, which activates various enzymes such as proteases and chemokines, which in turn leads to inflammation of the muscle cells, leading to degradation of the muscle. And there is also fibrosis, and there is impaired regeneration of the muscle. And the other factors are altered autophagy. That means the cell is not able to clear its content on its own, and activation of mesenchymal stem cells. And there is also inadequate new formation of the vessels. So new muscle is not able to form, which in turn affects various muscles such as skeletal muscle, cardiac muscle, and smooth muscle. Now let's talk about genetics and epidemiology. So I would like to discuss a little bit on genetics. So the common mutations seen are X-linked recessive mutation and autosomal dominant mutation. So in autosomal dominant mutation, if one of the parents is heterozygous, then 50% of the children will be affected. While in X-linked recessive, if the father is a carrier, then 100% of the daughter will be carrier and no sons will be affected. But if the mother is a carrier, then 50% of the sons will be affected and 50% of the daughter will be carrier. Now, in DMD and BMD, they are X-linked recessive mutation caused by mutation in the DMD gene. So the prevalence is 4.78 per 1 lakh people. In facioscapulohumeral muscular dystrophy, autosomal dominant mutation is seen, and the gene involved is DUX4. Prevalence is 3.95 per 1 lakh people. Limb-girdle muscular dystrophy. So the genetics is X-linked recessive and autosomal recessive. Prevalence is 1.63 per 1 lakh people. Emery-Dreifuss muscular dystrophy. So it is an X-linked or autosomal dominant mutation, and the genes involved are EMD and LMNA genes. So the prevalence is roughly around 0.39 per 1 lakh people. Next is myotonic dystrophy. Autosomal dominant mutation is seen in this kind of disease. And DMPK gene is seen in type 1 dystrophy, and CNBP gene is involved in type 2 myotonic dystrophy. Prevalence is roughly around 8.26 per 1 lakh people. Spinal muscular atrophy. The inheritance pattern is autosomal recessive and prevalence is roughly around 1 to 2 in 1 lakh people. So this prevalence is a rough estimate because estimating accurate prevalence is challenging because of the variation in the age of onset and the involvement of the muscle and also the complexity of the genetics. Now let's have a look at the findings. What symptoms can we see in Duchenne muscular dystrophy? So as I discussed earlier, that mutation in the DMD gene will lead to the absence of the dystrophin. So the connection between the cytoskeleton and the extracellular membrane will be lost. So muscle degeneration will begin and no new muscle will be able to form. So this leads to uh, affection of various muscles such as skeletal muscle death, cardiac muscle death, and smooth muscle death. So when the heart muscle is involved, it is accompanied by fibrosis, which ultimately leads to dilated cardiomyopathy, heart failure, and various arrhythmias. So when smooth muscle cell is involved, it affects the digestive muscles, beginning with esophagus, which can give rise to dysphagia, and affects stomach and intestinal muscles, which can give rise to constipation. So when the skeletal muscle cell is necrosed and accompanied by fibrosis, it can affect the respiratory muscles, which can affect the breathing patterns, which ultimately leads to decreased lung vital capacity and the inspiratory and the expiratory pressures. So this in turn leads to recurrent respiratory infections in combined with congestive heart failure. So these cardiopulmonary complications lead to premature death, commonly occurring between 20 to 40 years of age. And also the skeletal muscle, uh, there is false hypertrophy, meaning the muscle will be enlarged, but the muscle mass is not increased. And there is weakness in these muscles. So the skeletal muscle that leads to increased levels of creatine kinase. And this is one of the major tests used for diagnosing dystrophinopathy. And the skeletal muscle cell that also leads to exaggeration of the lumbar lordosis, which can give rise to scoliotic spine. And it also affects the mobility of the joints, causing restriction of the range of motion. So at around roughly around 2 to 4 years of age, the child will start having gait abnormalities. And around 4 to 6 years of age, he will have wide-based gait, leading to waddling type of gait, weakness in the proximal muscles, giving rise to Gover's sign, and eventually developing contractures in various joints such as ankle. And around 10 to 12 years of age, the child becomes wheelchair dependent. And in comparison to Becker's muscular dystrophy, the age of onset of muscle instability is roughly around 10 to 20 years of age. And in Becker's dystrophy, the patient usually can develop their ambulation and they can walk by adulthood. So we can say that Duchenne is of severe in nature and Becker's is a mild or moderate variant. So we can remember by that Becker is better. So this is the Gover's sign, which is commonly seen in DMD and BMD. So it commonly affects, the DMD commonly affects the muscles of the lower limb, and upper limb muscles are less involved. So due to the difficulty in the lower limb muscles, patient will not able to stand on his own. So he will make use of his hands to stand up. So you can see in this picture how the patient is trying to stand from sitting position. So continuing the clinical features. So as I discussed that DMD and BMD are X-linked recessive disorder. So it majority is common in male patients. Majority of the females are carriers, but they can develop symptoms in certain situations such as Turner syndrome, skewed X chromosome inactivation, translocation of mutated gene in autosome, or uniparental disomy. Now let's summarize the clinical findings. As we discussed earlier that the heart is involved, so it gives rise to heart failure, dilated cardiomyopathy, arrhythmias, and also mitral valve prolapse is a common finding. Musculoskeletal findings. So as we know that muscle is commonly involved in this condition. So it gives rise to muscle weakness, eventually leading to muscle contractures, leading to muscle instability, and eventually leading to muscle inactivity, which leads to osteoporosis and give rise to fractures. And other common findings are Gower sign, pseudohypertrophy, scoliosis, and toe walking. So now central nervous system findings. Cognitive dysfunction is commonly seen in DMD more compared to Becker's muscular dystrophy, and it is non-progressive in nature. Other features are seizures and hypersomnia. So due to hypersomnia, patient will sleep more in the daytime, eventually leading to headache and daytime tiredness, which will affect his daytime functioning. And ptosis is also seen, which give rise to visual disturbances. And respiratory muscle involvement is commonly seen, which give rise to scoliosis, chest deformity, recurrent pulmonary infections, respiratory insufficiency, and sleep apnea. Also, other findings are involvement of the bladder leading to urinary urgency, iridescent spots in the iris, problems with swallowing, passing stools leading to constipation and gonadal atrophy, and as well as increased prevalence of diabetes. Now let's have a look at what is toxicokinetics. So there are certain factors which affect the functioning of the muscle, such as nutrition and physical activity. So the more and the good adequate nutrition is there, the more the functioning of the muscle and strengthening will be happening. And interestingly, increased physical activity is associated with increased oxidative stress and inflammation. So, more the physical activity. So basically, caution should be exercised in these patients to avoid strenuous physical activity. And the next thing is chronic inflammation, which is also aggravating this condition. And the third thing is malignant hyperthermia. So care should be taken when these patients undergo surgery that inhalational anesthetics like halothane, desflurane are not used. Otherwise, it will worsen their condition. Now let's have a look at certain other types of dystrophy. Intermediate phenotype. So this group is called as outliers because it is best characterized between having mild DMD or severe DMD. And they usually become wheelchair dependent between 13 to 16 years of age. Another type is DMD associated dilated cardiomyopathy. So, as the term suggests, the predominant involvement is of heart muscle with little to no involvement of skeletal muscle. And some patients may have subclinical skeletal involvement consistent with BMD. And males typically develop heart complications such as DMD and heart failure between 20 to 40 years of age, and females usually develop complications at a later age. So, as I discussed earlier, that females who are carriers are commonly asymptomatic, but in 22% of cases, female carriers may have symptoms accompanied by the mutated dystrophin gene. The symptomatic female DMD carriers have variable age of onset and degree of muscle involvement or heart involvement. So serum creatine kinase is raised in 70% of DMD cases and 50% of BMD female carriers. However, they may decline with age, and some female carrier patients may not have increased creatine kinase levels. So it is very important to to undergo genetic testing to identify these carriers earlier. So now let's talk about differential diagnosis. So the muscle weakness can be seen in a lot of other conditions such as adrenal insufficiency, electrolyte imbalance such as sodium, potassium, magnesium, increased calcium level, problems with heme metabolism, some infectious diseases like rabies or hemiplegic migraine, towards paralysis, decreased glucose level, acute spastic paraparesis, myasthenia gravis, Pancoast tumor, and paraneoplastic syndromes. Now let's talk about different types of muscular dystrophy. Limb girdle muscular dystrophy. So, as the name suggests, there is muscle weakness involving the hip muscles and the shoulder girdle. So, sometimes it becomes difficult to differentiate between BMD and limb girdle muscular dystrophy in the patients who have negative family history. But some features are different in LGMD, such as calf muscle pseudohypertrophy is not as prominent in LGMD compared to BMD. And many patients who have DMD phenotype with negative dystrophin gene mutations should be tested for FKRP gene mutation because they might be having LGMD. Another type is Emery diffuse muscular dystrophy. So the thing that differentiates this dystrophy from BMD and DMD is the predominant, there are major symptoms such as contractures with involvement of humeroperineal pattern, cardiac conduction defects, and moderate elevation of creatine kinase. So another type is spinal muscular atrophy. So the main symptoms are decreased or absent reflexes, modest elevation of CPK. There may be fasciculations in the tongue, mini polymyoclonus, meaning hyperkinetic involvement affecting the distal limbs, problems with swallowing, respiratory insufficiency, and neurogenic electromyography pattern. Another common condition is myotonic dystrophy. So this happens due to trinucleotide repeat gene mutation, which is commonly seen is CTG repeats in type 1 and CCTG repeats in type 2. So the interesting thing about this myotonic dystrophy is it exhibits a specific feature such called anticipation, which means that the offsprings, meaning the daughter or the sons, will have the disease at earlier onset and more severe nature. We can remember the features of this condition by the trinucleotide repeat CTG. C meaning cataracts, T meaning taupe, meaning frontal baldness, G meaning gonadal atrophy. And as the term suggests, myotonic, that means it can lead to myotonia, muscle wasting. And the prognosis is variable, affecting multiple systems. Another type is facioscapulohumeral muscular dystrophy. So in this, muscle weakness is seen in face, shoulder muscles, and upper limb muscles. So it is commonly tested by doing genetic testing involving DUX4 genetic mutation. Prognosis is variable, may involve asymmetric muscle weakness. Now let's talk how to diagnose dystrophinopathy. So clinical suspicion can be done if the young child comes to your clinic with positive family history and has delayed motor milestones. And it is possible that young child may not have positive family history, but there may be other signs, symptoms such as not able to walk by 16 to 18 months of age, or presence of Goward sign, toe walking, or calf hypertrophy, or the child may have unexplained rise in AST and ALT. Now let's see how to diagnose which test should be done in order to diagnose DMD and BMD. So the first, the clinical signs and symptoms, as discussed earlier, like the child may be having muscle weakness or delayed motor milestones such as not able to walk properly or run or climb properly, and other features such as unexplained rise in enzymes such as AST, ALT, creatine kinase, family history of disease, and as well as other conditions such as having autism spectrum disorder or delayed cognitive deficits. So by this, we can clinically suspect that patient might be having dystrophinopathy. So the next step is to order creatine kinase level test, or you can refer to pediatric neurologist or neuromuscular specialist. They will also perform creatine kinase levels first. And if the creatine kinase level is normal, then dystrophinopathy is ruled out. But if it is elevated, meaning the level should be more than 2000 international unit per liter, then dystrophinopathy can be suspected. And after that, you should refer the child to pediatric neurologist or neuromuscular specialist or clinical geneticist. So the next most important step is to perform genetic analysis. And this is the confirmatory or gold standard test. So the first test is to look for deletions or duplications in DMD gene. And this is commonly found in 80% of people who have DMD gene mutations. And it is commonly performed using multiplex ligation probe amplification test or comparative genome hybridization. And if this test comes negative, then the next step is to look for small scale mutations in DMD gene. And it is seen in like 20% of people with DMD gene mutation. And it is performed using Sanger sequencing or next generation sequencing. And if it turns out negative, then the third step is to look for deep intrinsic mutations in the DMD gene. And before performing test for deep intrinsic mutation, muscle biopsy should be taken with dystrophin staining and Western blot test to confirm dystrophinopathy. And the next step is to look for to test for mRNA analysis so we can detect deep intrinsic mutation. And it is rarely seen in like 0.43% of cases. And after doing genetic testing, if dystrophin is present, then it means that it is not dystrophinopathy. And if dystrophin is absent and genetic testing is positive, then it is confirmed that the patient is having dystrophinopathy. And there is one thing which is called as reading frame rule, also known as Monaco rule. It is used to predict the severity of the DMD mutations. So if there is out of frame mutations, then the patient will be having DMD. And if there is in frame mutation, then the patient will be having Becker's muscular dystrophy. But there are 4 to 9% chance that the patient may not follow this or their patient may not follow this rule, meaning that the in-frame mutation can have severe DMD as well. So after confirming the diagnosis, it is very necessary to begin medical management as early as possible to prevent complications. And the next thing is mandatory carrier testing for at-risk female relatives. And also to test for other at-risk asymptomatic male relatives. And it is very important to provide genetic counseling to and to inform the couple to carry out the family planning. Now let's have a look how to manage the muscular dystrophy. So there are various interventions like medical, meaning by giving the drugs, surgical options, and other interventions. Now let's have a look about pharmaceutical interventions. As I discussed earlier, that heart involvement is commonly seen and it gives rise to dilated cardiomyopathy, heart failure. So antiarrhythmics play a very important role in managing the heart complications. And the commonly used drug is ACE inhibitors. And also it depends on the individual arrhythmias and individuals and their side effects. Also, in myotonic dystrophy, seizures are commonly seen. So antiepileptics play a very crucial role in managing seizures in these patients. And as the muscular dystrophy is having inflammation, so NSAIDs can help reduce the pain and inflammation. And as we know, the steroids are one of the strongest anti-inflammatory drugs. So usage of the steroids at administered dose of 0.75 milligram per kg per day can significantly slow the progression of muscular dystrophy for up to 3 years. But this effectiveness is not actually seen in Becker's dystrophy or myotonic muscular dystrophy and is still under research. But some individuals with facioscapulohumeral muscular dystrophy may improve with steroid therapy, particularly when rapidly progressive weakness is observed. So the another drug that is used is golodicin. This is the new type of drug, which is basically antisense oligonucleotide synthetic RNA. So it helps skip some exons during the synthesis of dystrophin. But this is still under research and the effectiveness not has been established yet. Now let's look at the surgical interventions. So the one way is by contracture release, which can help patient in ambulation, and heat massage and other things can complement this procedure. So if the patient is having cardiac complications, such as severe cardiac complications, such as having severe syncope or advanced cardiac block, in such situation, installing a defibrillator or cardiac pacemaker is helpful to manage the cardiac complications. And some patients having facioscapulohumeral muscular dystrophy, shoulder surgery might be beneficial for them, which because it helps stabilize the shoulder and their daily activities. Now let's look at other interventions. So the very important thing is to maintain the function in unaffected muscle groups in order to balance activity to avoid the hastening of the muscle fiber breakdown. The first is supportive physiotherapy. This is very important in order to maintain ambulation and affect the daily life. Second is supportive bracing. It is also equally important to maintain daily functioning of the patient, and the commonly used bracing is foot ankle prosthesis, commonly used in patients who have foot drop and sometimes wheelchair, especially for traveling. So it depends on the individual's muscle severity, environment, age of onset, and other factors. The third factor is vocational training and supportive counseling. As we know that it affects the child at a younger age, so it affects the psychosocial aspect of the patient. So it is very important to give the supportive counseling and to help them with activities of daily living, and it can help them manage their daily life. And equally important is to provide genetic counseling, especially to female carriers and to mothers. Radiation therapy is not the primary treatment for muscular dystrophy, but it is commonly used to reduce some symptoms and complication in some patients. But the area is still under research. So, what is the prognosis of muscular dystrophy? So the long-term focus should be on to maintain and preserve the ambulation and to monitor the complications of heart and lung. As we know that there have been advances in the muscular dystrophy treatment, but the disease still remains incurable and unfortunately lacks preventative aspects. So the most patients prematurely die from heart and lung complications before reaching 30. However, proper care and supportive counseling and all the supportive therapies can enhance the quality of life. So the complications commonly seen are bone demineralization, cardiopulmonary disease, disability, and anesthesia risk. So it is very important the people who undergo surgery of so the patients having muscular dystrophy who undergo surgery and particularly having general anesthesia. So it is very important to look for intensive post op monitoring. Thank you so much. So the references used by me were up to date, PubMed and Google.
Okay.
Thank you.
Okay. Stop